everybody, and welcome to another week of our Hospital Sungai Buloh CME. Today we've got a special presentation by two departments, by the medical department and dermatology department. It's a joint presentation. We are talking about the changing pace of monkeypox, so there will be two presenters. How will monkeypox affect us as a hospital? Just 3 points I wanted to raise. Firstly is that I think all of us are aware that the monkeypox cases all around the world are increasing. I think last they released the statistics more than a week ago. It was more than 30,000 worldwide, and every day was climbing by at least 1,000 cases. And we have reached places like Singapore and Thailand and Indonesia. So far in Malaysia, we have not reported any cases, but this is bound to change. We are bound to receive our first cases anytime, or perhaps they have already come because there's a long incubation period. Secondly is that we know that what we initially thought about monkeypox, that it presents very typically. Now we know that there are atypical presentations, and the speakers will be going through with you with that. And thirdly is we thought that monkeypox would be a mostly mild disease that can be treated as an outpatient. Now we know it is different. A significant proportion of these patients end up getting severe symptoms or complications which require prolonged hospitalization, and in rare cases even death. Yeah. So I think this presentation is especially of importance to people who work in emergency department, in surgical clinics or surgical wards, because patients can come in with just anal symptoms. ONG patients may present there. You can present to, of course, dermatology clinics and ENT. That's another very likely place they would turn up. Anybody who deals with oral lesions, whether ENT or dental, and of course medical and dermatology. All right. So without further ado, I will introduce our first speaker is Dr. Yong, who is one of the infectious disease specialists in our hospital. And halfway through, she will pass it to Dr. Norli, who is our well-known dermatologist in our hospital. So between the two of them, they will present to you, and then I will leave some time open for questions and answers at the end. All right, Dr. Yong.
Thank you, Dr. Ben, for the kind introduction. Good morning, everyone. I'm Yong from ID team. It's my pleasure to be able to present about monkeypox infection today with Dr. Norli from the Dermatology department. So I will start off with a brief introduction about monkeypox first. Monkeypox is caused by monkeypox virus, which belongs to a member of orthopox virus. It closely resembles smallpox and was first described in 1970 from a group of wild-caught laboratory monkeys. As far as we know, there are actually two clades of virus, one circulating in West Africa and then the other in Congo. And two of them actually have different in terms of their pathogenicity as well. One is in a milder form, and then the other one is in a severe form. So all these while, monkeys have been taking all the blame for causing monkeypox infection, but actually this is not the truth, because there are also certain reservoirs which can carry and also spread the virus. For example, a certain species of squirrels, Gambian pouch rats, dormice, or even non-human primates. How is monkeypox progressing so far? So we have our first reported case in a non-endemic country, which is USA, on 6th of May. So ever since then, the daily confirmed cases has been rising steadily every day. And up to last week, there's already more than 37,000 confirmed cases in non-endemic countries. For information, WHO has also declared monkeypox infection as a public health emergency since July 23rd.
Monkeypox
So there are 86 non-endemic countries been involved so far, including our neighbor country, Thailand and Singapore. Thailand itself, they already reported the 5th case, whereas Singapore, they have even more. They've already identified 15 cases in the nation. This is a case definition, which is released by UK Health Security Agency. Okay, so they classify the patients into possible, probable, and also confirmed case. Confirmed case is quite straightforward. It's when you have symptoms and you have a confirmed monkeypox PCR. But for possible and probable infection, how do they classify? So for possible cases, they suspect if the person has got febrile prodrome and they have a known prior contact, or they are deemed to have high clinical suspicion of monkeypox by the treating clinician itself. Whereas a probable infection, it's when a person has unexplained rash and they have a positive epidemiological link or history of travel to endemic countries for the past 3 weeks, or they're actually from a gay community or MSM. So the current global outbreak is very different from what we know in the past. And for current outbreak, the majority of the patients involved are actually young, healthy men with a median age of about 38 years old. Majority of them are actually from homosexual community, and 60% were HIV negative. To further elaborate whether HIV is related with monkeypox infection, as you can see here, majority of the population are still negative, HIV negative, and even though they're HIV positive with monkeypox infection, majority of them are on HAART with a well-suppressed viral load and a median CD4 of 664. So it does not necessarily only infect HIV patients who are immunocompromised. This is also a very important information to share. So this paper is published by NEJM, and what they found was actually majority of the patients actually presented to outpatient clinic or even emergency department. And this is the reason why it's important for all the first liner to be able to recognize and understand the basics of monkeypox. Next very important question is about how does monkeypox spread? So as far as we know, if you look at the current global outbreak, majority of the patients contracted the infection via sexual intercourse. But we also would like to highlight that it's not a typical sexually transmitted disease. Instead, saying that it is transmitted by semen or vaginal secretions, which is actually not a proven route of transmission yet. It's actually transmitted via contact to infected lesions, especially anogenital lesions, during the sexual intercourse. So do remember that it can also happen without sexual intercourse. The other route of transmission, of course, will be via respiratory droplets. That's why some of the reported cases actually is due to positive household contact. And other possible route of transmission will be animal to human transmission or vertical transmission. This is adapted from WHO website, which actually describe very well about the clinical course of disease. So as you can see here, the incubation period can range from 5 to 21 days, followed by febrile stage, whereby patient will develop fever and some systemic symptoms, which last typically around 1 to 4 days. And then they will go into rash stage, whereby they will start to develop skin rashes. Again, it will stretch in between 2 to 4 weeks before they go into recovery phase. So the total duration of illness usually will be around 3 to 4 weeks. Looking at the common clinical signs and symptoms, as you can see here, at the top of the list, rashes or skin lesions are actually the most common presenting clinical feature, followed by fever, lymphadenopathy, and other systemic symptoms. And as for skin lesions, the commonest location is still anogenital area, followed by trunks and limbs, face, as well as palms and soles. I will pass on my presentation to Dr. Norli to further describe about dermatology manifestation of monkeypox infection.
Selalu tak ada yang keruk ke yang driver nyata pun tak habis kata kita tunggu UTK punya pula penilaian apa tu selenggara.
Thank you, Dr. Jo. I will continue my presentation with the cutaneous manifestation of monkeypox. As we know that it is important for us as medical to understand, to know what is the presenting skin manifestation of monkeypox. So I continue with the presentation. Okay. Usually, monkeypox rash will begin 1 to 4 days of appearance of fever. So, following the prodrome, which is usually associated with fever, myalgia, and lymphadenopathy, the patient will start to develop rash following on the 1st to 4 days of appearance of fever, and the rash will continue for a period of 2 to 3 weeks. There are cases reported whereby there is no prodrome prior to the rash, meaning the patient was presented to the doctor with a rash without any complaints of fever or lymphadenopathy. So as you can see here, this is the rash which usually starts with a macular rash. It's just a patch, an erythematous patch. Well, you can see here, it's very thin, which can be the initial rash of monkeypox. It can subsequently evolve into papules, vesicles, and also into pustules. So we can see here, as seen in this slide, this is a vesicle with a surrounding erythematous vesicle here. Okay, and now this slide is also to share with all of you the cutaneous manifestation, where you can see here there is a pustule with center umbilication, and there's a lot of papules here with very clearly umbilication. What is umbilication? Umbilication is a central depression on the top of a lesion. So in monkeypox, the rash usually is concentrated over the face. It usually starts over the face, like you can see here. It's very extensive rash, macular rash of the face, and often develops on the palms of the hands and sole of the feet. And there are cases reported now that it may involve the oral mucous membrane, conjunctiva, anus, and also genitalia. So this is to show the evolution of the rash, how the rash progress from the day it appears until the 14th day of the rash. Okay. So it starts as early with a vesicle, which is less than 1 centimeter. A vesicle is a papule which contains fluid. So it later progressed into a small pustule, which is a papule which contains pus. There is a pus contained in this lesion. And later on, usually on the 7th day, there is an umbilication in the center of the lesion, which later on ulcerates in the center and progresses to become bigger into a scab. And later it will fall off and leaves a scale over the involved skin. This is how the rash is evolved. This is a real photo of a patient. You can see here, the lesion starts on the face. There is clear umbilication here. And I would like to show all of you that is involvement of the tongue, the oral mucosa, the same lesion occurring on the lips. And this is a lesion on the genitalia. There is multiple vesicles with a scab in the center. And here you can see a lot of papules over the penile area involving the scrotum with umbilication in the center. So the lesions eventually crust off. These blackish lesions are all crusting, or you call scab. Yeah, it will crust over and it starts to fall off typically on the 14th day of the infection.
So an individual is contagious until all the scab had fallen off and there is intact skin underneath. So when the patient still has all these lesions, the umbilication and the scab, the patient is still infective, and can transmit the disease to another individual. This is a case reported in India, just to say how the rash progressed. On day 4, you can see again there is a clear pustule with a center umbilication, right? On his body too, the same lesion is occurring here. It also involved the lips, the center umbilication, and also the genitalia, which already is beginning to scab. So on day 14, the lips are already clear, and you can see on the body it leaves a hyperpigmented patch, and the lips are almost clear, normal, but because of the deep lesion here on the genitalia, it leaves a hypopigmented scar. So apart from the rash that I've mentioned, the location that it occurs on the face, on the palms and sole, it can also occur at the anal area. Usually over the anal area, the lesions will be more to clustering lesion. So you can see here, there are a lot of clustered papule, and it actually mimics anal wart. So we have to take into account a very detailed history and also the exposure of the patient to differentiate whether we have to treat for anal wart or for monkeypox. So this is another example of a genital area involving the penile area. You can see that there is an umbilication, a vesicle with umbilication, and later leaves a scab on the 11th day. Same goes on the skin lesion. So a bit about the changing face of monkeypox, which was reported in this journal on July 21st of this year. The most common site now is the anogenital area, followed by the trunk, arms, and face of 55%, and palms and sole. The lesions are still the same that I mentioned: macular, pustular, vesicular, and clustered lesion. And what's different now is the rash can appear at multiple faces simultaneously. What we know before in monkeypox, the rash will appear at the same, the patient will have the same rash at the same face, but now it can appear different lesions at the same face. So among the person with skin lesion, they describe 58% to be vesiculopustular, and a high number of mucosal lesions involvement, about 41%, and also reported about 61% the patient has anorectal mucosa involvement. So these patients usually present with anorectal pain, proctitis, tenesmus, and also diarrhea. So when patient present with these symptoms and they have that lesion, we have to dig out more history to know whether we need to investigate further for monkeypox. So what are the differential diagnoses? Other viral infection, which is common that we always see, we encounter chickenpox, herpes simplex virus, and measles. STDs like secondary syphilis, lymphogranuloma venereum, chancroid, and skin infestation like scabies, and also not forgetting our drug rash. So this is a table to differentiate between monkeypox, chickenpox, and measles. So what is glaring here, which is the distinguishing features to differentiate between monkeypox and chickenpox, is in monkeypox, patient will present with lymphadenopathy. It may be single or it may be multiple lymphadenopathy. Whereby in chickenpox, they will not be, they just have the prodrome and they may not be lymphadenopathy as in chickenpox. And the appearance of the rash, it differentiates. In monkeypox, they will have they present with the same stage of rash. That means at the same time, they have the same lesion, whereby in chickenpox, they can present with polymorphic rash at the same time. All right, and as for the involvement, in monkeypox, usually it starts over the head and then it goes to the side, to the limbs, and also appears on the palms and sole, whereby in chickenpox, it starts on the head too, but it travels to the body and there is no involvement of the palms and sole. And this is what I meant about the polymorphic rash in chickenpox. Orang tekan. Ah. So this is what I meant about the polymorphic rash in chickenpox, where you can see, yeah, at this area, at this particular time, there is a scab here, there is papule, there is also vesicles, yeah, which has already ruptured. Yeah, there's all kind of rash is appearing at the same time, yeah, for chickenpox. And secondary syphilis is also a different diagnosis that we have to differentiate. Why? Because they also have macular rash, which can appear in monkeypox and the involvement of palms and so on. But how do we differentiate is that in secondary syphilis, the incubation period will be longer. Patient will have history of contact about 60 to 90 days prior to developing of all this rash like monkeypox. Okay, I will end up with this case report, yeah, which is published again in New England Journal in July 2022. So this is a young man, a 31-year-old. He is an RVD patient with a good CD4 count. He presented to the clinic with 1 week history of painless single genital rash. It's just a rash here. Just look like some you know, like mosquito bite, and then you scratch, just a thin rash here, and with a 2-day history of fever and sore throat. Prior to that, 3 weeks prior to that, he has unprotective intercourse with a new male partner. And they have done all the tests for syphilis, chlamydia, and gonorrhea, which were negative. However, they treated the patient for LGV and chancroid. So you can see here, very clear, there is umbilication over the penile area, and there is a scab in the center, which occurs 7 days after developing this rash at the inguinal area. So 5 days after the initial presentation, the patient returned with vesiculopustular lesions on the face and hands. So PCR was done over the lesion on the genital and the hands, which were positive for monkeypox. So within 2 weeks of the presentation, the patient lesions has cleared, yeah, without needing any specific intervention. So classically, the febrile prodrome will later on, the patient will develop rash and may appear on any part of the body, and it evolves simultaneously. But now, this current global outbreak, as we can see here, patient can come with painless anogenital lesions and often without prodrome like lymphadenopathy. And it is reported here that it is observed in persons who have had close contact with an infected person or persons, including those men who have sex with men. So with that, I end my presentation and pass it back to Dr. Jo. Thank you. Thank you, Dr. Norli, for the sharing. So moving on to additional symptoms of monkeypox infection, it's also very, very important to remember this, because the patient might just come to your clinic with these additional symptoms such as rectal pain, sore throat, or penile edema. They can also have blood, per-rectal bleeding, dysuvia, or even conjunctivitis. It's also nice to know that monkeypox can also cause severe complications, especially certain group of patients, for example, young children, immunocompromised patients, or pregnant ladies. They can be complicated with pneumonia or encephalitis. So there are reports and news saying that there's a possibility of monkeypox, asymptomatic monkeypox spread currently. So what they found was there was a paper which screened about 200 asymptomatic people for monkeypox, and 6.5% turned out to be positive. So among these 13 patients who were positive but asymptomatic, 2 of them developed monkeypox symptoms later. So that means that these 2 patients, most likely, they were in incubation period when they were being screened. But the remaining 11 will remain asymptomatic throughout the surveillance period. So this finding is actually quite alarming, because if, let's say, monkeypox can be spread asymptomatically, the story will totally be different. Okay, it would be like COVID-19 basically. But of course, we will need a larger scale of study to confirm this.
Okay, so the next question is how dangerous, how worrying is monkeypox? As I mentioned earlier on, there are already more than 37,000 patients been infected with monkeypox in non-endemic countries. So far, there were only 6 reported deaths. So the case fatality rate was roughly around 0.03%, which is very, very low. If you know a bit about monkeypox, traditionally the death rate ranges around 3 to 6%, and it can go up as high as 11%. So why is the current global outbreak contributing to a significantly lower mortality rate? We think there are a few reasons. First of all, the current global outbreak is likely diverged from the strain from Nigeria, which is the clade 3 virus. It is a milder form of strain compared to the strain in Central Africa. So this explains why the fatality rate is lower. The other reason is because we know that the current outbreak involves majority of young, healthy men from gay population. They are immunocompetent, they are from wealthy nation, they are more well-educated and more health aware. So they presented early and also they tend to have milder infection. And this is why the mortality rate is very, very low for the current global outbreak. So we can now send a PCR for monkeypox in Malaysia. We basically send it to IMR and MKAK. So do investigate if you have got patients who presented to you with unusual skin lesion, especially in anogenital area. So what we can send is either a swab from the skin lesions for PCR or even a blood sample for PCR. But we do recommend to send the skin lesion for PCR instead if the patient presented with skin rashes or lesions. Whereas for blood sample for PCR, it will only be useful when it is done in the early phase of disease when patient still has viremia. But no matter what, do remember about PPE. Put up proper PPE during specimen collection. Treatment-wise, these tables are from 2 different studies. The left side one was from New England Journal Med, and the right side is from a large study in Spanish. So both actually told us that majority of the outpatient will just be majority of patients will just be managed as outpatient, and the main reason for admission is basically due to for pain management or management for soft tissue superinfection. At the moment, we do not have antivirals specifically approved for monkeypox, but we do have this tecovirimat, which is an antiviral drug used for treatment of smallpox disease, but is currently granted for use for treatment of monkeypox, but in certain group of patients. It is only indicated for treatment if patients are immunocompromised, or they are pregnant, children less than 8 years old, or patients with 1 or more complications. And at the moment, there is also no indication for mass vaccination like what we do for COVID-19, but it's nice to know that we actually have got 2 vaccines available in the market. The first is Bavarian Norwich Genius vaccine. It's actually approved for both smallpox and monkeypox by FDA. It's a live vaccine with 2 dose series and it's injected 28 days apart. The other one is eCME 2000. It's only approved for smallpox, but currently it's granted for emergency use against monkeypox. It's also a live vaccine and it comes in a single dose. So in general, they are at least 85% effective at preventing monkeypox. Prevention is always better than cure. So what we can do is to learn from COVID. COVID has taught us so many things and it actually makes us more prepared in handling subsequent infectious disease outbreak after COVID-19. So do apply the knowledge that we use when we are dealing with COVID-19, and also educate about common presentations and also risk factors so that we know when we should suspect whether the patient has got monkeypox or not. Identify and isolate patient early is also a very, very important step. And last but not least, proper PPE when we are handling suspected or even confirmed cases. So I think everyone is quite familiar with the PPE by now. Basically, when we are dealing with suspected or confirmed cases, we should wear a face shield or goggle with an N95, gown, and also a pair of non-sterile gloves. And how should we isolate them? So we should put them in a negative air pressure room if it's available. If not, they should be in a single room with own attached bathroom. We should also apply standard contact and droplet precaution, as well as airborne precaution whenever possible, because there's a theoretical risk of airborne transmission. Good news here is, so far the risk for healthcare workers and healthcare associated outbreaks remain very, very low. So as of 11th of August, there are no cases being reported, which is transmitted via healthcare associated or occupational lab exposure. If a staff is unfortunately been exposed and without PPE on, they should undergo a 21-day surveillance. If they are asymptomatic, they can actually be allowed to work, but they cannot care for patients at high risk of severe disease. But if they are symptomatic, of course, the story will be different. They need to be isolated and to be investigated. So far, MySejahtera has also did a little upgrade, and they have added in this monkeypox alert function as well. It's designed for travelers who are going to travel abroad to high-risk countries. So basically, we need to fill out the surveillance form, and it's for risk assessment later on. So far, there are also still things that we do not know well about monkeypox yet. First of all, we do not know until what extent children, immunocompromised patients, or pregnant ladies are at risk of severe disease. And we are also not sure whether immunosuppressed patients, they have more virus in their body fluids or not. The other thing is whether monkeypox can actually spread via aerosols. So WHO acknowledged the potential for respiratory transmission back in June, as well as short-range aerosol transmission. They found that there's a possibility of transmission if we are handling patients' equipment, for example, their clothes, the bed sheets. Okay, there's a possible of short-range aerosol transmission. But so far, there are no cases of long-range airborne transmissions, and there's also no report about transmission during brief interaction. Last but not least, we also are not sure whether monkeypox virus can be actually spread through semen or vaginal fluids. And but so far, what we have found is viral DNAs can actually be detected in semen. In conclusion, after the presentation today, we hope that everyone can at least recognize the common manifestation of monkeypox, understand how it is transmitted, so that we will know when we should suspect, to isolate the patient and refer. With that, I will end my presentation today. Thank you very much.